Good evening, everyone. On behalf of Iota Upsilon Lambda chapter of Alpha Phi Alpha Fraternity's COVID Education and Outreach Program, our chapter president, Kevin Johnson, distinguished members of the National Center for Children and Families, and the Black Physicians Healthcare Network, I would like to welcome everyone to our final COVID-19 awareness and education webinar entitled, Are We Protected? My name is David Luckett, a proud member of Alpha Phi Alpha Fraternity, and I'll be moderating this evening's important event. We've been enduring this pandemic for over 2 years now with unheard of numbers of deaths, losses of employment, changes in the way we do our jobs, and the often unspoken mental stress and breakdown this virus has thrust upon us all. It's easy and understandable to throw caution to the wind and speed toward regaining what we may consider our normal way of life. Although we've been resilient, our current mortality and severe illness has curtailed significantly, it is imperative for us to stay informed and alert as this virus is ever changing and it's oblivious to what we're going through as a society. Its only mission is to replicate, multiply, and survive. Things are changing rapidly, and many of us are unsure where things stand regarding vaccinations, boosters, and drug therapies. And that is why Dr. Benjamin, as well as the many distinguished panel members that have been a part of these program sessions, have sacrificed their time to speak to us, and it's my honor to introduce him to you this evening. Dr. Benjamin is a well-known health policy leader, practitioner, and administrator who currently serves as executive director of the American Public Health Association, the nation's oldest and largest organization of public health professionals. He is also a former Secretary of Health for the state of Maryland. Dr. Benjamin is a graduate of Illinois Institute of Technology, Go Tech Hawks, and the University of Illinois College of Medicine. He is board certified in internal medicine, a master of the American College of Physicians, a fellow of the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, and a member of the National Academy of Medicine. At APHA, he serves as publisher for the American Journal of Public Health, the nation's health newspaper, and APHA Press, which is the association's book company. He serves on several nonprofit boards, such as the Research America, the Truth Foundation, the Environmental Defense Fund, Ceres, and the Reagan-Udall Foundation. He is also a former member of the National Infrastructure Advisory Council, a council that advises the president on how to best assure the security of the nation's critical infrastructure. George is a longtime friend and fellow alumni from Illinois Institute of Technology, and I'm elated that he graciously agreed to serve as our guest speaker today. Without further ado, ladies and gentlemen, I present to you Dr. Georges Benjamin.
Hey, David, thank you for allowing me to spend a little time with you. What I want to try to do is just spend a little time talking about COVID-19, give us folks a kind of an update on what we think it is, and talk a little bit about what we think it's going. Just to remind us, this is a respiratory virus. It is, I like this picture because it kind of shows you what happens. This is a sneeze. You'll notice that there are large particles, there are small particles. Those particles really don't go very far, which, we talk about standing 6 feet away from somebody. This kind of gives you a sense of what that spray looks like from a big sneeze. Those big particles are what we call droplets, and those little small particles get aerosolized. It can float around in the air for a while, and we're going to talk about that in just a moment. But I just want you to continue as we talk about this to visualize this, because this is a predominant way that people get this disease. You get this disease from somebody else who has shared respiratory secretions with you, and generally in one form or another. Now, we know that these kinds of infectious particles can pass from person to person through, like I said, droplet spread. This is why the mask works. I'm again come back to that as well, because it frankly blocks the vast majority of those droplets from coming from one person to another. So if I wear the mask and you wear a mask, it protects me from you and you from me. But we also know that these smaller particles do hang out in the air. And then, of course, when they settle on the ground and they get disturbed, they can resuspend in the air. So aerosolization is another way that people can get it, but it's not the most common way. Regardless, a tightly fitting mask protects one, reduces your risk. And everything I'm going to say tonight is about risk reduction. And like everything else in medicine, nothing is 100%. But it dramatically reduces your risk from getting this particular infection. And then we have what we call fomite spread, which is where the virus resides on the surface. So I contaminate my hand, I contaminate a table, I contaminate a doorknob. You come behind me relatively shortly, you touch it, you get the virus on your hand, and then you self-contaminate your eyes, your nose, your mouth. And then that gets into your system that way. That is not a common way the virus spreads. It seems to die pretty easily, although there are really great lab studies that show that it can stick around for a while, sometimes several hours. So it's important to know that it can happen, but with routine cleaning, just the kind of cleaning you normally do in your home, with the routine cleaners that you use every day and the kind of cleaning we do in the office, you can, again, dramatically reduce the risk from fomite spread. Now, this has been the worst infectious disease of its type in the last 100 years. And I just want to pay respect to HIV/AIDS because clearly that's been the worst pandemic we probably have had, certainly in my lifetime. But for this one, the last time we saw an infectious respiratory disease like this was in 1918, 1919, when we had the great influenza. COVID-19 is caused by a virus called SARS-CoV-2. Globally, there's been over 500 million cases, as you can see, over 6 million deaths. In the United States, we've had over 87 million cases and over a million deaths. And that's one of the real challenges we have. When we got that first 100,000 cases, I think most of us thought, that was a tragedy. And if we got to 200,000, that would be a real tragedy. I don't think that any of us ever thought we would get to 1 million deaths. And I think that's been one of the concerns that we had, is that we've lost far too many people through this pandemic. Now, just to point out that the vaccines that we have are highly safe and highly effective. Today, we have over 222 million people fully vaccinated. We've got about 47% of the people who are eligible vaccinated. About 26% of the people over age 50 who needed to have boosters also have had their booster shot. So we've done quite well. I mean, even though we still don't believe that we have all the people that should be vaccinated, we've actually done well. I mean, to get this many people vaccinated in the time period that we have is actually a public health success. Now, we often talk about the vaccine, and when the studies were done, when we initially created this vaccine, the endpoint was severe hospitalizations and death. So we know, you can see from this graph that the people that are vaccinated, which is the green line at the bottom, are well protected. The early part of the pandemic, before we had a vaccination, deaths and those populations pretty much mirrored one another. But we had clear separation when we got a really good, safe, and effective vaccine early, later in the pandemic. And then hospitalizations, again, a similar pattern. Highly effective vaccines to prevent people from getting really sick and dying. Now, we all know that there have been some challenges in terms of reinfection, and vaccines actually do two things. Number one, they prevent you from, and teach your body to protect itself from getting really sick and dying. The other thing that it can do, but not always, is totally prevent you from getting infected. Well, these vaccines actually turn out to be pretty good at keeping people from getting infected or reinfected, but they're not anywhere near as good as with preventing severe morbidity and mortality or illness and death. We also know that one of our challenges globally is that we really just haven't done a really good job of vaccinating the rest of the world. And that blue line that's going very high shows that those are our lower income countries. And of course, the high income countries, which are at the lower end of that, have done much better than the higher income countries. And we just have to do a lot better job of this. So what's been changing over time? Well, the virus has changed, and we've had several new variants. Right now, about 50% of the variants that we're seeing crop up from people who've been infected are the BA4 and BA5 variant. It's a significant change in the virus, and that's one of the real things that's changed over the course of this pandemic. As you may remember, also, we didn't have a lot of tests early on for the pandemic, but quite frankly, now we have an abundant level of home self-tests, so much so that people are doing lots of home tests, so we don't necessarily have a good sense completely of the trajectory of the virus because people are self-testing, and we don't really know the denominator, because if they self-test and they're negative, they're not reporting it to anybody. And certainly a lot of people who are self-testing and positive are also not reporting it to anyone. Having said that, one of the things I want to encourage all the listeners right now is to check the expiration date on your tests, because we're coming up to the expiration date on a lot of the tests that people bought. So if you need to use them, use the ones that are about to expire first. Secondly, we had some issues with adequate access to vaccines. We certainly still have some vaccine hesitancy. We do now have a vaccine for kids under the age of 5, and we're going to talk about that. So they're no longer on the way, they're now here. Our antivirals are actually pretty good. We do have some limited amounts of these vaccine antivirals, which is a supply line issue, but that's rapidly correcting itself. And we now know that the monoclonal antibodies, which are antibodies that we draw off from people who have been infected, and then we use in other people to fight the infection. With some of these variant changes, we're now beginning to see that the monoclonal antibodies as a therapeutic tool can be less effective, particularly with the Omicron variant. The good news is that we have this uptick in cases with little increase in overall mortality. So even though we're having a wave right now, depending on where you are in the country, we had it up in the Northeast initially, then it plateaued, and now it's getting better. We're now beginning to see that increase in our southern cities. So as I mentioned, we're doing a lot of home testing now. And so one of our challenges, of course, is measuring the trajectory of the disease. We've got lots of mechanisms to do that. People get reported to their health department or through their healthcare provider, physician, nurse practitioner, PA. That gets reported ultimately into the system. CDC has these systems that are in place to actually track the disease. Hospitalizations, of course, get reported. We have this novel way of testing where the disease is going, because it turns out that the virus gets excreted in your stool. It's no longer infectious, but you can measure it. And so we've discovered that if we measure wastewater on an ongoing basis, we can predict sometimes several days ahead of an outbreak that the outbreak is occurring, because we're beginning to see it show up in the wastewater in our communities. We also know that anytime we have an outbreak, the public health department goes in and does what we call a epidemiological assessment. So that helps us figure out where we have these clusters. And of course, if you self-test, you turn positive, and then you report that to your health department or to your provider, that's another way for us to bring that data together and track the trajectory of the disease. And of course, we're in a technological age, and we have these really neat tools, these proximity apps, where I know in Maryland, we have these apps where if my phone is always talking to somebody that's also volunteered to have the app on their phone. So if one of us becomes positive and we report it, it goes into the system and it remembers that I was around another person who had that phone-to-phone connection. And then it notifies the system and it notifies me that I was exposed to somebody. And of course, then it tells me I should go get checked. Certainly if I have symptoms, I should go get checked. But all in all, there is some unreliability about this because we've now moved to kind of a broad community-based way of trying to self-test on an individual basis. And so we do lose some of the sensitivity of the broad way of trying to find the trajectory of this disease. They've done some studies where they've gone in, they've drawn blood, and they've done tests on that blood. And it turns out, this was a study that looked at people from September of 2021 through February 2022, and about 50% of the population had become infected, even without being vaccinated. So we know that there's a substantial number of people that had COVID. Some knew they had COVID, and some never knew they had COVID. And as David pointed out early, when he introduced me, these viruses, they live to evolve. They go in, they infect an individual, and then they make millions of copies of themselves. Sometimes they make copies that are perfect copies. Sometimes they make copies that basically change their character or their ability to transmit disease. Sometimes they change a little bit. Sometimes they change a lot. But the characterization that occurs in these new variants is all about how easy or difficult it is for them to transmit themselves from one individual to another, whether or not they change in a way to create a more severe disease, and whether or not they can evade our vaccines or some of the therapeutics. So transmission, disease severity, and the ability to evade our diagnostic tools and our protective tools like vaccine are the three characters that we look when we're tracking these viruses over time. So the big strain that's hit us right now with a bunch of substrains, subvariants, is the Omicron variant, which is much more infectious than Delta. Delta was the kind of the second or third, depending on where you were in the world, strain that we were exposed to. And vaccinated people who do get infected with or without symptoms can be contagious, although it turns out if you're vaccinated, you're much less contagious if you've been vaccinated. And our data on how sick this disease, this virus makes people, particularly in vaccinated people, continues to evolve. So a lot of what we're learning, we know from what we know today, and of course, tomorrow we'll know more. And so I think that's important because we know the science changes based on our knowledge and our study of these disease processes. Now, again, just to reiterate that these vaccines are highly safe, highly effective, and do indeed protect us from severe illness, hospitalizations, and deaths. And we now have some early treatment modalities that also help us, particularly for high-risk people. High-risk people include people who are overweight, people who have diabetes, who have heart disease, who have lung disease, chronic kidney disease, are also people who are at higher risk. If you have asthma or chronic obstructive pulmonary disease because you smoke, If you're a smoker, you're at higher risk of getting sick should you get infected from SARS-CoV-2 and you get a more severe case of COVID-19. Again, not for everybody. It's about 15 to 20% of the people who get infected get a severe case of the disease. We're also beginning to see a little bit of escape from some of our rapid tests and our therapeutics. So sometimes people test themselves multiple times before they become positive, even though they may very well be symptomatic. And that's a manifestation of how much virus you have in your symptoms, your system. And if you're vaccinated, it may take longer for you to get enough virus in your system. You might get symptomatic before your test turns positive. Now, when we started this thing, the CDC didn't really have an adequate system to do the sequencing, to look for variants. Britain, Israel had really robust systems to look for those variants. But as you can see here now, they've corrected a lot of that. They really have a growing system to be able to rapidly identify both at the through federal labs as well as private sector labs to identify the sequences, to catalog them and share them with the public and the other professionals who are trying to manage this disease. Now, one of the things CDC did do in recognition of the fact that we were getting a lot of people vaccinated, and then we had a lot of people, for one reason or another, who didn't get vaccinated, who did get infected, and infection does provide a degree of protection. Probably not as well as vaccination, which is why we still encourage people to be vaccinated, even if they were infected, is that they looked at vaccination levels, the fact that we had these therapeutic tools, the fact that our hospitals were no longer being inundated, and the fact that we can generally still recognize the overall prevalence of the disease in the community, despite my previous statements about our ability to really, really accurately predict the exact trajectory. We have a really good sense of community prevalence based on all those ways of reporting that I showed you earlier. So they came up with a community level of red, yellow, green. It's kind of a stoplight chart. If you're in a community that is green, it is about, means that you have a low prevalence of the disease floating around the community. If it's red, it's very high. And of course, median's right in between. When they first put this out in February, this is what the nation looked like. It was a hodgepodge of counties, some red, some yellow, some green. And then over time, we did quite well. But then, of course, we saw the impact of the Omicron spike that had started late in the fall last year. And with that, we began to see this map again changing. I think the benefit of using this stoplight chart, and what I do, quite frankly, is every week I go and go to the CDC website and I look at the community stoplight chart and try to look at anywhere I'm traveling and where I'm living to get a sense of community spread. And I use that to help me manage my activity or to advise my employees at the Public Health Association. And what these things allow us to do is say, you should wear a mask or you don't have to wear a mask, or masking is optional. It helps us with our testing strategy. It helps us inform high-risk individuals of what their relative risk is if they go to an event or dinner or out with friends. And of course, it helps us to find very specific recommendations for our hospitals, our healthcare system, people going to school. Summer is happening, so we can give people advice about summer camps, things like that. And as you can see, under these three different categories, we continue under all of them to encourage people to get vaccinated. But I think the big change here is, what do you do in terms of what your underlying medical risk is and whether or not to wear a mask or not. So clearly in a red community, you should be wearing a mask indoors particularly even schools. If you're in a green community, the masking is not necessary unless you choose to, or you have an underlying chronic disease. And certainly, if you're in a transitioning community, which is one of the yellow communities, you should, and particularly if you're at risk or in a crowded setting. So I was just flying back from Texas just the other day, and I wore my mask on and off, depending on where I was in the airport and on the plane when I felt I needed to wear the mask. So this will give you a sense, again, reminding you that that's where we started. We had gotten really neat or mostly low risk communities. And here's where we are on the 23rd of June. And again, there's a patchwork, but still mostly green. But from a population perspective, knowing that there are population density in places like California, they still have significant ways to go before they again return to green in that state. The other thing CDC did was they created a new forecasting center in order to be able to do a better job of giving us advice. You ought to think about this as the National Weather System, right? The National Weather System tracks the weather. They feed that information to the meteorologists around the country. The meteorologists then tell us whether it's going to be a dry day or a hot day or a rainy day. And then using that information, we can decide to put on a hat, wear a raincoat, take an umbrella where we go. The analogy, of course, is when we know this, we can tell a community is going to be a red, yellow, or green community. We can, again, decide whether or not we're going to wear a mask or not, whether we're going to go to a big event, whether we're going to have a big event or not, based on that information, and defining ways in which we can try to mitigate the risk for people as we go forward. And so the good news is we spent a fair amount of money. Congress has appropriated this money to build this center. And I tell you, it's beginning to do its work, and the information that's beginning to come out of that is actually phenomenal. Now, one of the setbacks we've had is that we've had a lot of legal issues where people have been challenging public health authority. And one of the real challenges, of course, was we had a mandatory mask requirement for public transportation in place. And of course, some of you may know that was challenged, excuse me, challenged in the courts. It's under appeal right now, but you're no longer required to wear a mask in public transportation, although it's important to know that CDC still strongly recommends that if you're on public transportation to wear a mask, particularly anytime you're around a bunch of people for whom you do not know. And I believe that one of the things that we were kind of thinking about when this pandemic first started, the United States was not a mask-wearing society. Many of the communities, nations in Asia, wear masks all the time. Anytime there's a respiratory outbreak, they put on their masks. Many of them people wear masks in public transportation as a matter of habit, of practice in those communities. I project that we are going to become a society where many people are going to wear masks anytime they feel they're at risk. And I think we're going to have a big societal change from that perspective. And I always get asked, even though I say masks work, sometimes I get people that just don't believe me. And so this is, there are many charts like this, but this is Kansas. And Kansas, the governor permitted communities to decide to make masks mandatory during the height of the pandemic. And what you can see here is those within the state of Kansas, those counties that required masking had a dramatic reduction in COVID, which is a red line. And those counties that didn't maintain their level of infection throughout this portion of the pandemic. And everyone who's looked at this within their communities and have done this, what is in essence is a natural history study of the infection, have found that these masks work. And again, the masks work because the predominant way you get infected is through droplet spread. and the mask simply acts as a physical barrier to preventing you from getting infected from the virus. I also tell people when they ask what kind of mask should I wear, certainly you're not protected at all if you don't wear a mask. And the cloth mask is good. It reduces your risk by about 60%. That surgical mask gives you another 10% protection. And these high filtration masks, the N95 masks, technically they filter out about 95% of the particles. But each of these gives you, for practical purposes, about a 10% reduction in your relative risk of getting exposed to the virus. You know, exposure and infection and then getting sick from the infection are three different things. But a tightly worn, properly fitting mask, particularly an N95 mask, is the best protection you're going to get. But the cloth mask, for people who find that more comfortable, more reliable, easier to use, is certainly an acceptable way to reduce your exposure to COVID-19. So we now have a vaccine for kids under 5 years of age. I often get asked, why did it take so long for us to get here? Obviously, we know this virus was safe and effective in adults. Kids are not little adults. They have a developing immune system. We know that tragically, since COVID started, we've had over 2 million cases, over 20,000 hospitalizations, about 200 deaths in kids under the age of 5. But we always start with doing the vaccination in adults that are healthy. Then we go to healthy pregnant women, and then we go to kids. And for kids, the issue is trying to get the right dose that is safe and effective in these kids. And eventually they were able to get enough kids in the study at the right dose. Initially, we were concerned that the doses they were using just didn't give the kids the protection that we thought they should have. But they got enough kids, they did enough studies, and now we have a safe and effective vaccine. By the way, it's from 6 months to 5 years of age. And I also often get asked, why not under 6 months? You know, when a woman who is pregnant or who's been exposed to COVID has a child, and we're hoping, by the way, we don't want pregnant women to get infected with COVID. The outcome for those babies is not as good as kids who have now, of course, been expected in utero. So hopefully a vaccinated pregnant woman, when the child is born, like all other antibodies, she passes her maternal antibodies to that child. So for the first 6 months, that child is in fact protected from COVID if the mom was vaccinated. And then over towards the last part of those 6 months, that protection begins to wane. And now we know that we have both Pfizer and Moderna both have an approved vaccine. As I mentioned, the dose is much lower than the adult dose. No serious side effects. Kids do get fevers, they get sore arms, a little redness, just like everybody else does. The Pfizer vaccine is a 3-dose vaccine series. The Moderna vaccine is a 2-dose vaccine series. There is no booster for these kids yet. There's no recommendation for a booster. With the one exception that kids who have underlying immune compromise, based on the recommendation of their doctors, they may choose to give them an additional dose as they go forward as part of that process. But right now, for most kids, it's either the 3-dose or 2-dose dose with Pfizer or Moderna. We actually have another vaccine that's been approved by the FDA. It's called Novavax. It's a different vaccine. The 2 mRNA vaccines use a portion of messenger RNA. They inject that in you. Your body takes that up. It creates this protein, that spike protein that you see on all the pictures. Your body produces that, and then your body recognizes that as foreign, and then you make antibodies against it. What Novavax does is actually creates the T protein, the spike protein, and injects that directly in the body. So it doesn't have to be converted in your body. And at least the studies show that it produces a reasonable, and some would argue a highly effective antibody response in doing that. Time will tell, but of course it takes one step in the process out, which I think is also a good thing. So we'll see. We're also pretty excited here in Maryland because the company that actually makes this is actually in the state of Maryland. So where do we go from here with vaccines? Well, we're looking very much at second generation vaccines. As you know, most of what we've talked about is this change in the virus, the fact that it continues to change and mutate. And just like when we have influenza, when you get your flu shot every year, you're getting a collection of different variants that they've sat down and the scientists have looked at it and the epidemiologists have said, these are the most likely strains we're going to see in the fall. And then they create the vaccine to protect you from that strain, and you get a flu shot every year, which is a little different from the flu shot you got the year before. We're going to be doing the same thing with the vaccine against SARS-CoV-2 to prevent us from getting COVID-19. And most likely it will be at least a bivalent vaccine, means at least two strains in it. Most likely right now, the Omicron variant. Just recently, the FDA, just the other day, approved and recommended that we go to a vaccine for this fall that will be different than the vaccine in terms of the composition of variants in that vaccine for those of us who will then need to get a vaccine in the fall. We don't know exactly who will be the recipients of that vaccine in terms of being recommended to get it, but there is going to be a new different vaccine in the fall. And we know that antivirals work. So right now, the vaccine antiviral of the day is a drug called Paxlovid, which is a combination drug of two of the more common antiviral agents. You usually get it for somebody who's in a high-risk category within 3 to 5 days of positive tests or symptoms, which then you find out is positive. And you take this drug and it reduces dramatically your risk of getting really sick and dying as an additional protection for people who are vaccinated or as a protection for people who have never been vaccinated. There is a small percent of people who get rebound symptoms. It's not a failure of the drug. We're still not quite sure why people get a return in their symptoms. I actually just saw today, some of you may know, Dr. Tony Fauci did get COVID. Mild case, was doing fine, took Paxlovid because, he's 81 years of age. And he did apparently have some rebound symptoms. The question about how contagious you are when you get return of symptoms, I think remains to be seen. There is some evidence that you may very well have some degree of infectivity, but we're still studying that. And hopefully in the next few months, we'll have a better understanding of the impact of Paxlovid and what the relative risk is on someone who's been treated and then gets return of symptoms. This is a growing concern, and this is one of the major arguments for getting vaccinated. You don't want to get this disease if you can avoid it. You certainly don't want to get this disease if you're unvaccinated. That's a really, really important thing to try not to do. Because the virus impacts every single organ system of the body. And quite frankly, with a small number of people, leaves them with a range of issues from heart failure to inability to taste or smell to kind of a brain fog. Neurologists don't like you to use that term, but it's brain fog. You're not really thinking clearly, kind of feeling foggy, skin rashes, arthralgias, myalgias of your muscle, sometimes chronic cough, chronic shortness of breath. So there's a range of things that are being, and the NIH is studying this. And hopefully over the next year, we'll learn a lot more about long COVID. We'll learn a little about what vaccines do to protect you from it, whether or not there's any therapeutic options to you, whether or not the antiviral agents help you with long COVID. All those studies are being done today, and hopefully in a year or so, we'll have better answers to that. And I know people are tired of waiting, but the truth of the matter is it's a new disease. And we're still learning things about heart disease and cancer and diabetes. So we're always going to learn new things with this disease. Well, there is a bottom line, and that bottom line is vaccines work and they're safe and effective, particularly in their ability to reduce severe illness and death. They do reduce contagion, but not as effectively as they reduce severe illness and death. I need to reiterate that because people sometimes use the fact that it doesn't completely protect you as a reason not to get vaccinated. That's not a reason to get vaccinated. In fact, probably only reason for not getting vaccinated is having a severe allergy to the vaccine. It benefits all ages. Its effectiveness does wane somewhere between the 5 and 6 month period. We begin to see some waning of its effectiveness. And in the presence of chronic disease and age, you're much more likely to get reinfected. I think these second generation vaccines we're about to put, as I mentioned earlier, are essential to us getting that done. We still have a lot of work to do globally because until we get everybody kind of protected, we're still going to have variants developing. And the variants are our biggest risk for one of these variants to change so dramatically that is more infectious and more lethal. That's still a big risk out there. And we're also going to have to update the therapies, antiviral therapies and tests as the viruses mutate. We're going to need to update those tests and therapies as well. We do have some concerns going forward. Issues around supply line, particularly for a global disease like this, remains a real challenge. Health workforce staff, in fact, staffing everywhere is a challenge. We're still having a lot of people that have outbreaks as we continue to go through these patterns of outbreaks, and a whole workforce can be decimated for several days. Our testing capacity right now is okay, but over time there's worry about that. We need to get better at giving people regulatory advice, particularly now that the courts are stepping in more and more and undermining some of the core public health authorities that we've had for over 100 years. We've got to deal with this issue around vaccine mandates and again, maintaining public health authority to be able to mandate it when we need to mandate it. When I talked about the global vaccine access issue and the fact that may have no new variants, I think another thing to watch is this animal to human potential for transmission. Right now, minks are the animal that we're kind of concerned about, but there actually was a case of a person they believe was infected by their cat. So animals can get this disease, and we've had several mammalian species get this disease. We know that coronaviruses there are mammalian coronaviruses, and so we knew that people, again, can get it, but not to panic because it shouldn't be a big deal for us as we go forward. But we are watching it. I think this fall is something to watch. There are many of us who think there'll be a surge. Why? Because respiratory diseases always surge in cold weather. The fact that we're going to have some waning of our immune status. But the impact of that surge depends on the viral strains that are there, what our vaccine level is, how much we have waned as a society, whether we're going to be wearing masks or not, what the availability of some of the therapies are. All those things will feed into how big or how small a surge develops. Might we go without a surge? We might. And that's also a possible future for us. I think the potential for this multivariant vaccine for the fall means that we're probably going to have an annual shot. I would not, I can't be predictive for sure, but I would not be surprised if this becomes an annual event, just like the flu shot. There are some issues around funding. The administration went to Congress asking for $22 billion to be able to invest in next generation vaccines, new tests, to try to vaccinate the rest of the world. And that has not been come through. So the administration pulled $10 million from the testing program to jumpstart the new development of vaccines and the new development of antiviral agents. And that is going to be an issue we're going to have to deal with. But that pulls money from the testing program. So one of my forward-leaning concerns is will we have enough tests as we go forward? Right now, the government, our federal tax dollars pay for this directly for our government. At some point, this is going to need to be transitioned to the private sector. So in essence, your insurance would pick this up in a normal course of things. But in the short term, we do need to continue to lobby Congress to get this funding request through. So with that, let me stop. Let me thank you. And David, I'm available to take questions.
Georgia, thank you so much for that incredible presentation. This was exactly what we needed, and we do have a list of questions. I'm going to start these. So many questions that actually have come in. I'm getting them on my, I'm getting them text to me. So I'm not sure if that is our Facebook Live audience who knows how to get in touch with me, but we're going to go ahead and look at some of these questions right now. The first one is, can you explain the term viral load and how that relates to the COVID infection and the effect vaccines may have on that phenomenon?
Yeah, viral load basically is the number of viruses you have in your body at any one time. Obviously, the more viruses you have, the more infected you are. And the vaccine does reduce the amount of virus you have in your body and the amount of, and how fast you get infected and how fast the virus replicates. So if you have a high viral load, you're much more likely to get sicker. Also, you're much more likely to, not always, but much more likely to be more contagious. It also depends on where that virus is. So if it's higher in your respiratory tree, so you're expressing the virus when you cough or sneeze, you're much more likely to infect somebody. If it's lower in your respiratory tree, you're much more likely to get sicker, but you may be less likely to be more infectious.
Excellent. Thank you so much. We've got several other questions here, so I'm going to go ahead and go through them. The first question is almost of someone who has actually received 2 doses of the Pfizer COVID-19 vaccine and 1 Pfizer booster. And it seems that COVID is here to stay for a while. Do you predict annual boosters similar to the annual influenza vaccine? I think you've answered that one already, but is there any issue in getting the vaccine of one manufacturer versus the booster of another?
Yeah, so the short answer is yes. So I actually did the same thing. I had 2 Modernas, 1 Moderna booster, and then I decided, because I saw a paper that said they might get a little bit of better coverage, I took one of the Pfizer. My second booster was a Pfizer. I got a second booster because of age and because I have some underlying chronic diseases. So I fell into that category of people that were recommended to get a booster. So the answer is yes, you can mix and match. Now, for kids, they're telling kids they ought to, what they start with, they ought to finish with. Mm-hmm. I think as we go to boosters, that may change. But in general, for your primary series, that is either the 2 or the you should get, or the 1 with the J&J. You should stay with your your primary brand until you get your primary series done, and then the boosters, it's okay to mix and match.
Excellent. Thank you so much. Next question. Have we reached herd immunity due to the current variants not killing as much of the population as compared to the onset of COVID-19 pandemic years ago that we had? So where are we in regard to herd immunity?
Yeah, I would let's throw that term away. It's a great term. But we're nowhere near anything that I would consider herd immunity. Why? Because, yeah, we're probably at herd immunity for the Alpha variant and the Delta variant, but we're not at herd immunity for the Omicron variant. And so as long as we continue to have these variants that happen, we're not going to be able to break the spread. So what herd immunity is that there's enough protection, enough people that either have either have had the disease, therefore they're no longer getting highly infectious and becoming contagious, or been vaccinated. And that combination of those groups breaks the spread of the infection. The problem is that that's true for the variants that we had initially, but we keep getting new variants, and those new variants present an increased risk of contamination or contagion, and then of course people getting sick. So I think the concept of herd immunity, we talked about it a lot early. By the way, we talked about that a lot earlier when we thought we had what was called extinction vaccination, and that's when the vaccine is so effective in keeping you not only from getting sick and dying, but also very effective from keeping you from infecting other people and spreading. Turns out it's less effective for that. It is effective, but less effective. So I would not even use the term herd immunity. I'd avoid it.
Thank you so much. Next question. And this is in regard to some of the home tests that are available. Are home tests as effective as the PCR tests? And are there any legitimate concerns with false positives?
Yeah, so tests, they're false positive and false negative with all tests. And the PCR is certainly the more definitive test. But the self-test is a good screening test. And so, you know that you were out at an event and you come back and you get the sniffles and you want to know if you got COVID. You do your self-test and you're negative. Now, you might have to test yourself again a day or two later, but it's a pretty good test. Even with these variants, it's a pretty good test. It gives you a peace of mind. The one difference and challenge is the PCR, once positive, is positive for a much longer period of time. So you can clear yourself of the infection and still be PCR positive for several weeks afterwards. So, I encourage people, you get the PCR test when you really, really need it and you really need to know. You can also use the PCR test as a confirmatory test when necessary. But I encourage people to get to use a self-test. But as you're traveling, you're going overseas, you really need to know whether you're positive or not, because it makes a difference. Certainly the PCR test is a definitive test, and probably the way to go when you really have to know.
Thank you. And another question related to that. After you get through COVID, you're told not to test right away. The statement is that there are molecular structures of the defeated virus still within your system. Can you provide some validity to that statement?
Yeah, absolutely. So when you do an antigen test, what you're measuring is the presence of a physical part of the virus on your in your nares or in your throat, depending on how the test is done, the test you're doing. Usually we're doing nose tests these days. So it's basically you have the way to think about it, and this is not exactly right, but dead virus versus live virus. Mm-hmm. So you still have a piece of the virus around your body. This test is picking up that piece of the virus. Your body hasn't cleared itself of all those proteins, and they turn up positive if you have enough of them. PCR, by the way, you have to take the virus and it replicates the virus. So now you have an actual replicating virus. And that's why the PCR can be more specific for an active infection. But yeah, the idea is and that's why they tell you, you've tested, you're positive, you wait for a while before you retest. And a lot of folks tell folks not to retest. We know that the broad clinical course of the disease is somewhere around 10 to 14 days, from initiation of infection to clearance. Yeah, there's some people that still are infectious a little bit outside that 10-day period, but we think of that 10 to 14-day period as kind of, so for just basic work, think 2 weeks. Once you're out 2 weeks, you're fine. And because every day after that 10 days, or actually 5 to 7 days, you're less and less infective, which is why they say, okay, you're now tested, you're positive. After those first few days, you can wear a mask and you can go out and you can engage other people because you're less infective with that mask on. But if you're going to be around, grandma who's really sick or has immunocompromised, I encourage people to wait a couple weeks.
All right, thank you so much. Our last question. Based on CDC guidelines, should we be concerned more with infection rates or transmission rates?
I think we should be more concerned about hospitalizations and deaths. Because at the end of the day, that's what we care. We care about anyone getting sick. But at the end of the day, people who get really sick and the rate of people who have to go in the hospital or who die right now is the barometer. Because there's so much self-testing out there. We have no sense of the denominator. So we can't say a % of the disease is accurate because we don't know the denominator. It would be nice to know that there are a lot of diseases in which you get infected, but you don't get sick. We walk around all the time with staphylococcus or streptococcus on our bodies. Some people carry it without it making them sick in their posterior pharynx all the time. But if they drink after someone or kiss someone and they can transfer the disease and that other person's susceptible, they may get infected. Or if they have surgery, they may have a surgical infection. So it's important to differentiate between being a carrier or being infected. And I think we lost David. So I'm sure he'll be coming back. Let me just say that we have only, we've only gotten rid of one disease, one infectious disease, made it extinct, and that was smallpox. That took a Herculean effort worldwide to get rid of it. So anyone who's waiting for this disease to go away, I think we're all fooling ourselves. We are close to putting polio in that category. But of course, violence around the world in the places where we still have some resident polio has prevented us from being able to do that. But with the exception of smallpox and getting close to polio, I think guinea worms is another disease in which we've done a really good job of getting rid of. We haven't had a lot of total success in getting rid of diseases, and so I think that's one of the real challenges that we have. People are expecting this thing to wake up one morning and for it to be different. This disease has totally changed our lives. It's going to be around. We're going to have to figure out how best to live with it as it changes to whatever form it changes to. And as we think about this disease going forward, I think we're going to have to invest in strong public health systems, strong medical care systems, and ensure that those systems are there to protect us. Because the truth of the matter is, as I tell people, public health saved your life today. You just didn't know it.
Oh, so sorry, folks. I got knocked off, but I am back. And again, we want to thank Dr. Benjamin for his incredible presentation. Thank you so much for joining us. And again, thank you to the communities that have taken time to listen to this very informative and very important program. We will be letting you know about new initiatives that Alpha Phi Alpha Fraternity Incorporated will be holding in partnership with the National Center for Children and Families, as well as the Black Physicians Healthcare Network. Until then, we employ you all to have a great summer, be safe, and look forward to having you at another network webinar in the near future. Thank you again, and good night.